My name is Shang-Ren Xu. I'm an attending physician at the Division of Endocrinology and Metabolism at Changhua Christian Hospital in Taiwan. And for this session, I will discuss with you about diabetes care in older adults, pregnant women, and youths. According to the estimates of the International Diabetes Federation, currently 1 in 11 adults 20 to 79 years of age have diabetes, which amounts to 463 million people in the world. In particular, the proportion is much higher among the older population, with 1 in 5 people over the age of 65 years afflicted with diabetes. Also, there are currently over 1 million diabetic children and adolescents in the world, most of whom have type 1 diabetes. Additionally, there is a very great proportion of pregnancy, about 1 in 6 live births, that is complicated by hyperglycemia. And so this topic will focus on diabetes care among the old, the young, and the pregnant patients. First, we will discuss the care of older adults with diabetes. According to the recommendations of the American Diabetes Association, in caring for older patients with diabetes, one should consider assessment of the medical, psychological, functional, and social geriatric domains in order to determine the targets and therapeutic approaches for their management. Especially, the older patients should be screened for geriatric syndromes such as polypharmacy, cognitive impairment, depression, urinary incontinence, falls, and persistent pain, which may affect diabetes cell management and diminish quality of life. Diabetic patients should be screened for cognitive impairment and dementia when they reach 65 years of age and re-evaluated annually as appropriate. Hypoglycemia should be carefully avoided in older adults with diabetes, as they may worsen complications from hypoglycemia than younger patients. Glycemic goals should individualize for each patient, especially since the elderly have a higher risk of hypoglycemia. The duration of their diabetes is usually longer. They have shorter life expectancy. They may have multiple associated comorbidities and diabetic complications. And depending on their functional capacity, they may be more passive in their own care. And so therefore, a less strict glycemic target with the HbA1c leaning toward 8.5% may be more appropriate for the older adults. Accordingly, we can divide the patients into 3 groups: those who are relatively healthy, those who have complex or intermediate health problems, and those who are in poor health and have very complex health problems. Those who are healthy may have more stringent glycemic goals, including an hemoglobin A1c of less than 7.5%, fasting glucose less than 130 milligrams per deciliter, and bedtime glucose less than 150 milligrams per deciliter. Those who are intermediate may have the A1c goal raised to 8%, fasting glucose up to 150 milligrams per deciliter, and bedtime glucose up 150 milligrams per deciliter. Whereas for those who are in poor health, an A1c of 8.5%, fasting glucose 180 milligrams per deciliter, and bedtime glucose of 200 milligrams per deciliter should be sufficient targets. As for the choice of pharmacotherapy, particular preference should be given to medication classes with a low risk of hypoglycemia. Overtreatment should be avoided, and for those who are treated with complex regimens, one should try to de-intensify or simplify the treatment regimen in order to reduce the risk of hypoglycemia and polypharmacy, provided the A1c target can be achieved. For the elderly as well as the younger adults, the drug therapy of first choice is metformin if the initial HbA1c is not excessively high and the patient is not symptomatic from hyperglycemia. Metformin is highly effective in lowering blood glucose and yet has little or no hypoglycemic risk. However, one must be aware of the risk of lactic acidosis in patients with organ failure, especially those with impaired renal function. If metformin alone is insufficient or if there is contraindication to its use, then another agent may be added or substituted for metformin. For the elderly, the second agent should preferably have low hypoglycemic risk as well. All of the currently available anti-diabetic drugs except insulin and insulin secretagogues such as sulfonylureas and glutamate have very little or no risk of hypoglycemia. So essentially, any agent beside insulin and insulin secretagogues can be chosen if there are no contraindications. For elderly patients who are on a complex insulin regimen, we may try to simplify and decrease dosages as appropriate to reduce hypoglycemic risk. For example, for patients who are on the basal bolus insulin regimen, we may change the injection time of basal insulin from bedtime to morning and reduce dosage as necessary to keep fasting glucose above 90 milligrams per deciliter. The mealtime insulin may be gradually decreased while an oral agent is added and increased until the mealtime insulin can be discontinued. And for patients who are on a pre-mixed insulin regimen, an attempt can be made to replace it with a once-daily basal insulin, which is simpler to administer. For elderly patients with advanced organ failure, the prevention of hypoglycemia is of even greater significance, but they are also at risk of dehydration from hyperglycemia, which must also be prevented and treated. As oral intake decreases, insulin and agents that may cause hypoglycemia should be reduced in dosage. And as for the patients near the end of life, it may be reasonable to discontinue all diabetic medications as they are unlikely to have any oral intake. But a small amount of basal insulin may be given to patients with type 1 diabetes in order to prevent acute hyperglycemic complications such as ketoacidosis. Now, this is a case example that I have seen in my clinic. The patient was an 84 years old woman who was diagnosed with type 2 diabetes more than 6 years ago. Besides diabetes, she also had hypertension, ischemic heart disease, Parkinson's disease, and diabetic nephropathy. She weighed only 47 kilograms and was thin and frail in appearance. She was referred to my clinic because she had occasional episodes of hypoglycemia in the afternoon, with blood glucose down to around 30 to 40 milligrams per deciliter. However, her fasting glucose has been mostly within 110 to 120 milligrams per deciliter. Her food intake was irregular and her appetite sometimes poor. Her hemoglobin A1C was 6.7%, which may be good for a typical adult diabetic patient, but is actually a bit low for an elderly patient like her. Her cholesterol level is only modestly elevated, and she had acceptable renal function. Her diabetes medications included glimepiride, which is a sulfonylurea, metformin, vildagliptin, which is a DPP-4 inhibitor, and a basal insulin glargine, which she injected at bedtime. So after reviewing her medications, I discontinued her glimepiride, which is an insulin secretagogue and the most likely culprit to cause her afternoon hypoglycemia. Whereas metformin and vildagliptin were continued, since these two drugs are much less likely to cause hypoglycemia. I also reduced the insulin dosage from 20 to 16 units and changed the time of injection from bedtime to morning in order to reduce the risk of nocturnal hypoglycemia. After the adjustments in medication, the patient's blood glucose had been kept within 100 to 200 milligrams per deciliter. The hemoglobin A1C had risen to 7.2%, which is still very acceptable for an elderly patient like her. And most importantly, she had no more hypoglycemic episode. The second case was a 90-year-old woman with type 2 diabetes since about 20 years ago. She also had stage 4 chronic kidney disease, hypercholesterolemia, bronchiectasis, osteoarthritis, and a recent humeral fracture. Her fasting blood glucose had been within the target range of 90 to 130 milligrams per deciliter. However, she would sometimes have hypoglycemic episodes with glucose level down to below 80 milligrams per deciliter in the afternoon. She had good food intake and was reasonably well nourished. Her most hemoglobin A1C was 7%, which may be fine for younger adult patients, but may be too low for an elderly patient like her with risks of hypoglycemia. Her lipids were well controlled, but she had poor renal function with an eGFR of only 22.4. Her medications included twice daily injections of a pre-mixed insulin, Humalog Mix 50, which contains 50% of rapid-acting insulin lispro and 50% intermediate-acting lispro protamine. She was also taking atorvastatin for control of her cholesterol level. And so considering her risk of hypoglycemia with a premixed insulin, I substituted her Humalog with once daily injection of a basal insulin, which was insulin degludec at 25 units each morning. That was about 70% of the total Humalog dose she was using previously. I did not consider the use of oral anti-diabetic agents because her renal function was poor, and I wanted to keep her treatment regimen as simple as possible. After the adjustment in medication, her blood glucose became more elevated. Her hemoglobin A1C had risen to 7.5%, but which was still very acceptable for a patient of her age and condition. Moreover, she had no more hypoglycemic episodes afterwards. Next, I will consider stopping her atorvastatin, since at her age, it probably has very little benefit in terms of cardiovascular risk prevention. And so these cases illustrate that for elderly patients with hypoglycemic risk, diabetes medications should be simplified and de-intensified whenever possible, especially if the patient is using insulin or insulin secretagogues. And a less stringent glycemic target should be set that are appropriate for their age and condition. And next, I will discuss the care of diabetes in pregnancy. And this group of patients include women who are known to have diabetes since they became pregnant, or those who were found to have hyperglycemia only during pregnancy, which we term gestational diabetes. Diabetes confers certain risks on pregnancy, including spontaneous abortion, fetal anomalies, preeclampsia, macrosomia, neonatal hypoglycemia, hyperbilirubinemia, and neonatal respiratory distress syndrome. Moreover, the offspring of a diabetic mother has increased risk of obesity, hypertension, and type 2 diabetes later in life. It is therefore very important to keep the mother's glucose level as near normal as possible during pregnancy in order to prevent these complications. For the pregnant women without diabetes history, but with risk factors for diabetes, such as obesity and glucose intolerance, we would screen for gestational diabetes by doing either a one-step 75-gram oral glucose tolerance test or a two-step 100-gram oral glucose tolerance test when the mother is at 24 to 28 weeks gestation. And for the women already known to have diabetes, preconception counseling should be part of routine diabetes care starting at puberty when the patient reaches reproductive potential. It is important to optimize the patient's glycemic control before becoming pregnant, and so prior to that, effective contraception should be used. The patient should be told that it is important to keep glucose levels as close to normal as possible, ideally achieving an hemoglobin A1C of less than 6.5% in order to prevent pregnancy complications. And during pregnancy, women with pre-existing diabetes have a greater risk of development or progression of diabetic retinopathy. They should therefore have a dilated eye exam before or during the first trimester of pregnancy, and then monitor every trimester and for 1 year postpartum. During pregnancy, the glycemic targets are comparably more stringent than during the non-pregnant state. The ADA and the American College of Obstetricians and Gynecologists recommend a fasting glucose of below 95 milligrams per deciliter and either 1 hour postprandial glucose level less than 140 or 2 hour postprandial glucose less than 120 milligrams per deciliter. The Taiwan guideline recommends essentially the same glucose targets with the addition of a glycated albumin level of less than 15.8%. And the reason to use glycated albumin level as a measure of average glycemic control is that the hemoglobin A1C is slightly lower in pregnancy than in the non-pregnant state due to increased red blood cell turnover, and therefore may not be very accurate. Glycated albumin reflects the level of glycemic control in the preceding 2 to 4 week period and is not influenced by hemoglobin levels. But if the hemoglobin A1C is used as the measure of glycemic control, ideally a target level of less than 6% should be achieved during pregnancy. However, if there is significant risk of hypoglycemia, the target may be relaxed to 7%. For pregnant women with gestational diabetes, lifestyle behavior change is the most essential component of diabetes management and may be sufficient for many women without the addition of pharmacotherapy. However, if lifestyle change is insufficient to achieve glycemic targets, then insulin therapy may be added. In some countries, metformin or glyburide may be added during pregnancy. However, these oral drugs are not recommended for pregnant women in our country, since both drugs cross the placenta and may affect the fetus. Likewise, other oral anti-diabetic agents and non-insulin injectable drugs, such as the GLP-1 agonists, are not recommended, as the long-term safety data for pregnant women are lacking. For pregnant women with pre-existing diabetes, insulin is also the preferred agent for achieving glycemic control. And for patients with type 1 diabetes, either multiple daily insulin injections or continuous insulin infusion pump can be used during pregnancy. Besides glycemic control, hypertension and proteinuria in pregnant patients should also be treated if blood pressure is consistently above 135/85 millimeters mercury. However, blood pressure below 120/80 should be avoided, as it may impair fetal growth. Some commonly used medications for diabetic patients, such as ACE inhibitors, angiotensin receptor blockers, and statins, should be stopped when the patient is pregnant, as they are potentially harmful in pregnancy, and other safer antihypertensive drugs such as calcium channel blockers should be used instead. Immediately after delivery of the child, insulin resistance will decrease dramatically, and insulin requirement often becomes roughly about half the pre-pregnancy requirement for the initial few days postpartum, and so insulin dosage may need to be readjusted. After delivery, women with gestational diabetes should be screened again for diabetes at 4 to 12 weeks postpartum using the 75-gram oral glucose tolerance test, as many will have confirmed diabetes at this time. And this is a case example that was seen in my clinic. The patient was a 27-year-old woman with type 1 diabetes since 12 years of age. Her diabetes was complicated with nephropathy, and she also had hypercholesterolemia. Her glycemic control was not optimal, as she had hemoglobin A1C of 7.3%, and she had elevated blood glucose levels. Her cholesterol level was elevated also, and she had microalbuminuria. And during a routine clinic visit, she announced that she was found to be pregnant for 7 weeks. At that time, her blood glucose had been frequently above 200 milligrams per deciliter. Her medications included injections of rapid-acting insulin aspart before each meal and insulin glargine once daily as basal insulin. She was also taking atorvastatin for hypercholesterolemia. So upon receiving news of her pregnancy, we changed her insulin glargine to detamir, which has more safety data for use during pregnancy. Atorvastatin was discontinued immediately, as it is potentially harmful during pregnancy. We also referred the patient to a dietitian specialized in managing pregnant women with diabetes. And after nutritional assessment, the dietitian developed a specific meal plan for her, including the daily calories and the amount of each type of food recommended for her to be taken each day. The patient was also instructed to check her blood glucose multiple times every day. And by using our diabetes telecare service, she could transmit the glucose data to our hospital using a mobile phone application. And upon receiving the glucose data, our diabetes educator and dietitian would give her instantaneous advice on how she could adjust her diet and insulin dosage in order to bring down her blood glucose levels. And although more stringent glycemic goals are generally recommended for pregnant women, hypoglycemia should be avoided as well. Since this patient was found to have frequent hypoglycemia on her glucose measurements, we had set less stringent goals for her and allow her hemoglobin A1C to be up to 7%, fasting glucose up to 130, and post-meal glucose up to 150 milligrams per deciliter. And after such intervention, the patient was able to keep her blood glucose mostly within limits, with a follow-up A1C of 6.8%. She was able to complete her pregnancy uneventfully and deliver a healthy infant at 37 weeks. Now, lastly, I'm going to discuss the care of children and adolescents with diabetes. Most of the young patients will have type 1 rather than type 2 diabetes. And before the age of 18 years, they may not have adequate ability or understanding to sufficiently care for themselves. And so the parents or an adult caregiver must be involved, and they must be provided with culturally sensitive and developmentally appropriate individualized diabetes self-management education and support. Individualized medical nutrition therapy is especially important and should be incorporated into the overall treatment plan for young patients with type 1 diabetes. Attention should be paid to psychosocial issues and family stresses that can have negative impact on diabetes management. If necessary, the patient should be referred to a trained mental health expert. As regarding glycemic control, the majority of young patients with type 1 diabetes should be treated with intensive insulin regimens, including basal and prandial insulins, or with continuous subcutaneous insulin infusion, if available. They should check their blood glucose levels multiple times daily, including before each meal and before bedtime, and as necessary for safety when performing certain tasks or when having symptoms of hypoglycemia. And just as for the adults, the targets of glycemic control should be individualized and reassessed over time. And hemoglobin A1C of less than 7% is appropriate for most children. However, less stringent goals, such as A1C of less than 7.5%, may be more appropriate for patients who cannot communicate symptoms of hypoglycemia, those who have hypoglycemic unawareness, or those who cannot check blood glucose regularly. And even less stringent HbA1c goals, such as less than 8%, may be appropriate for patients with a history of severe hypoglycemia, have limited life expectancy, or have extensive comorbid conditions. On the other hand, a more stringent A1C goal of less than 6.5% may be set for those patients who can achieve such goal without significant hypoglycemia and without negative impacts on well-being or undue burden of care. One must also be aware that some autoimmune diseases are more prevalent in patients with type 1 diabetes, and the patients should be assessed for these conditions soon after the diagnosis and if the symptoms develop. In particular, serum TSH and antithyroid antibody levels should be checked to screen for the presence of autoimmune thyroid disease. And IgA tissue transglutaminase antibodies should be checked to screen for celiac disease. And blood pressure should be measured at each routine visit. Elevated blood pressure is defined as greater than or equal to the 90th percentile for age 6 and height for children, and between 120 and 129 millimeters mercury with diastolic pressure less than 80 millimeters mercury for adolescents. And hypertension is defined as greater than 95th percentile for the children and greater than 130/80 for the adolescents. And patients with elevated blood pressure should initially be managed with dietary modification and exercise. Pharmacologic treatment should be considered if target blood pressure is not achieved within 3 to 6 months. And for the young patients as well as the adults, the initial pharmacologic agent of choice for hypertension is either an ACE inhibitor or an angiotensin receptor blocker. The goal of treatment is blood pressure within the 90th percentile for age 6 and height for younger children, or less than 120/80 for children older than 13 years of age. Blood tests for lipid levels should be obtained when initial glycemic control has been achieved, and if abnormal, should be managed with optimization of glucose control and medical nutrition therapy. For children older than 10 years of age, the addition of a statin may be considered for those who continue to have LDL cholesterol level above 160 milligrams per deciliter or above 130 milligrams per deciliter, plus one or more cardiovascular risk factors. The goal of therapy is to achieve an LDL cholesterol level below 100 milligrams per deciliter. The patients should have annual screening for diabetic nephropathy by obtaining a random urine sample for albumin to creatinine ratio once they reach puberty or are older than 10 years of age, once they have had diabetes for 5 years. If the albumin to creatinine ratio is above 30 milligrams per gram, then treatment with an ACE inhibitor or an ARB may be considered. The patients should also have an eye exam to screen for diabetic retinopathy once they have had type 1 diabetes for 3 to 5 years, and which should be repeated every 2 years. And along with the increase in the rate of obesity, the incidence of young patients with type 2 diabetes has also increased over the past 20 years. It is therefore recommended to screen for diabetes among children who are overweight, namely those with BMI above the 85th percentile, or those who are obese with BMI above the 95th percentile, and those who have one or more additional risk factors for diabetes. The screening should be done once they reach puberty or are 10 years of age, and either fasting plasma glucose, 2-hour plasma glucose during a 75-gram oral glucose tolerance test, or an hemoglobin A1C can be used to test for diabetes in children and adolescents. And if diagnosed with type 2 diabetes, the patient should receive comprehensive self-management education together with their families, just as for type 1 diabetes. Patients who are overweight or obese should be provided with a lifestyle program that aims to achieve 7 to 10% decrease in excess body weight. And as for drug treatment, young type 2 diabetic patients should be treated with metformin if the initial hemoglobin A1C is less than 8.5%, which is then titrated up to 2,000 milligrams per day as tolerated by the patient. If the initial hemoglobin A1C is above 8.5% or blood glucose is above 250 milligrams per deciliter, and the patient is symptomatic with polyuria and polydipsia, then a basal insulin should also be administered along with metformin, starting at a dosage of 0.5 units per kilogram per day and then adjusted according to blood glucose levels. However, if the patient presents with diabetic ketoacidosis or hyperglycemic hyperosmolar state, then intravenous insulin should be given and then changed to subcutaneous insulin injections as acidosis and hyperglycemia resolve, just as for type 1 diabetes. Young diabetic patients should also be screened for pancreatic autoantibodies if such tests are available. Metformin should be continued if they are antibody negative, but should be switched to multiple daily insulin injections if antibody positive, since these patients may actually have type 1 rather than type 2 diabetes. A recommended hemoglobin A1C target for most young type 2 diabetic patients treated with oral agents alone is less than 7%. But more stringent targets such as A1C of less than 6.5% may be applied if it can be achieved without significant hypoglycemia or adverse effect. And for the management of nephropathy in young type 2 diabetic patients, urine albumin to creatinine ratio should be obtained at the time of diagnosis and then annually thereafter. For those with elevated blood pressure, initial management is to increase emphasis on lifestyle management to promote weight loss. But if the blood pressure remains above the 90th percentile or is above 120/80 after 6 months of lifestyle intervention, then an antihypertensive medication should be added. Just as with type 1 diabetic patients, either an ACE inhibitor or an ARB is recommended as the initial antihypertensive drug treatment. Young patients with type 2 diabetes should also be screened for diabetic neuropathy by performing a foot examination at diagnosis and then annually. Diabetic retinopathy should be screened for by performing a dilated fundoscopy or retinal photography at the time of diagnosis and annually thereafter. Prevention of neuropathy and retinopathy should focus on achieving the glycemic targets. And now this is a case example that was seen at my endocrinology clinic not long ago. The patient was a 17-year-old woman who was diagnosed with diabetes at the age of 14 years. She was of normal height and weight and had normal blood pressure. Her most recent hemoglobin A1C was 6.6%, which was not too bad, although her glucose level often fluctuates between 130 and 200 milligrams per deciliter, and with occasional hypoglycemic episodes. Initially, she had elevated cholesterol level, but it was brought under control with medical nutrition therapy. She had normal renal function and had no significant albuminuria. And she was treated with mealtime injections of insulin aspart 3 times a day with dosages ranging between 13 to 20 units according to the blood glucose levels and food intake. She also injected a basal insulin, which was insulin degludec at 38 units at bedtime. And the patient had very good family support with both parents and even the grandparents involved in her care. However, in the past month, she left home for college and was busy with schoolwork and making new friends. And due to the pressure from her peers and the stress of the new environment and lifestyle, she began to neglect her insulin injection. And one day, she was brought to the emergency room of our hospital for nausea, vomiting, and dyspnea after having had no insulin injection for the past 2 days. She was found to have diabetic ketoacidosis with markedly elevated blood glucose level and the presence of serum ketone and a low arterial blood pH. After treatment with intravenous insulin infusion, IV fluid hydration, and electrolyte supplements, her ketoacidosis resolved. She was discharged home in stable condition. And so this case illustrates that children and adolescents with diabetes are likely to have lapses in their care when they enter a new phase of life and adopt a different lifestyle, especially if they are away from their parents or caregivers. And so during the time of transition, they should be referred to a diabetes educator and a dietitian to reinforce self-management education. And when appropriate, they should also be referred to a social worker and a mental health expert for psychosocial evaluation and support. And so in conclusion, older adults, pregnant women, and young patients present challenges in diabetes management that are different from typical diabetic patients. The diagnosis, screening, diet and lifestyle modification, pharmacologic treatment, goal setting, and complication prevention and management must be tailored to the particular characteristics of each group and continually modified as the patient's condition and their needs change. Currently, there's relative lack of supporting evidence in the management of these groups of diabetic patients. And so diabetes care worker must continually update knowledge in these areas as new information becomes available. Thank you.